Thank you. Dr. Camilleri will conclude with discussion on physiology and pharmacology of gastroparesis. Michael.
Thanks, Eddie. Thank you to the organizers for the opportunity to be at this inaugural meeting. And of course, I would never stab you. And the only reason why that consensus document in Nature didn't include pyloric stent was the concern among the consensus writers that there was a high prevalence of migration of the stents. But I think as we move forward, obviously that will be another way in which it could certainly enter into the algorithm. So what I propose to do is to review some aspects in 15 minutes of the stomach physiology in patients with symptoms suggestive of gastroparesis, review some of the pharmacotherapy for gastroparesis and what might be down the road, talk about the stomach physiology in obesity, pharmacotherapy, and then the combination of pharmacotherapy with devices and newer medications. So the first point I want to make is that not all symptoms that suggest gastroparesis are actually caused by what was defined previously, which is a delay in gastric emptying in the absence of mechanical obstruction. So we did a study of almost 1,300 patients, reviewed over about 10 years at Mayo Clinic, and all these patients had gastric accommodation and gastric emptying measured. Now, we had developed a technique to measure gastric accommodation non-invasively, not having to put a liter bag into the stomach. And that imaging technique allows us to measure in a 30-minute outpatient examination the size of the stomach by imaging. And as you can see, approximately a quarter of the patients who come to us with symptoms suggestive of gastroparesis have delayed gastric emptying, a quarter have impaired gastric accommodation, a quarter have both, and a quarter have neither. And those are patients that we think have gastric hypersensitivity. Also, let's remember iatrogenic gastroparesis, because so many times we identify factors that are remediable by changing management. Obviously, and David Katzka is going to talk a little bit later about the role of the vagus nerve and the possibility of post-surgical gastroparesis. But in my practice, I see a lot of patients with diabetes, and you need to look at the details of what the patient is given, because amylin or pramlintide and the GLP-1 agonists like exenatide, liraglutide, semaglutide, all those medications that finish in tide are all GLP-1 agonists, and they delay gastric emptying. Our diabetology colleagues love them because that delay in gastric emptying reduces postprandial glycemia, but they may be pushing the patient into the gastroparesis symptoms. Remember, a DPP-4 inhibitor like vildagliptin or sitagliptin will not delay gastric emptying. So you can make a judgment call and talk to your endocrinology colleague and see whether they can replace the GLP-1 agonist with a DPP-4, dipeptidyl peptidase 4 inhibitor, because that will not delay gastric emptying. And similarly, in those few patients that we see post-transplant, remember, some post-transplant anti-rejection medications can delay gastric emptying. Finally, opiates. There is no such thing as a mu opiate agonist that does not delay gastric emptying. Two negatives. Therefore, opiates all delay gastric emptying. Even tapentadol, which was brought along because it's a norepinephrine reuptake inhibitor plus a minor mu opiate agonist, turns out to have exactly the same gastric emptying delay as oxycodone, and we proved that in a study. News. It used to be said that there's no relationship between gastric emptying and symptoms. Well, I have news for you. 2 papers published in the last year. First, there is an association between delayed gastric emptying and symptoms if you measure the gastric emptying properly. Only 2 criteria are needed. Use a solid meal and study the gastric emptying for at least 3 hours. And if you do that, a systematic review and meta-analysis shows that if you optimally measure gastric emptying, there is a relationship between gastric emptying delay and nausea and vomiting, the 2 predominant symptoms. In addition, in a paper that's just appeared in Gastroenterology, if you give a prokinetic, a pro-motility agent, you will see a direct relationship between optimally measured gastric emptying and improvement of symptoms. So it is worth treating delayed gastric emptying in patients with these types of symptoms. The pharmacological treatment is summarized here, and quite honestly, this is an algorithm that I published in the New England Journal about 20 years ago, and it has changed very little, unfortunately. Still, we only have one medication approved, and that is Metoclopramide, and we all know about the baggage around Metoclopramide. So I'm just going to talk about, yes, we can sometimes use low doses of erythromycin for a short period of time. Remember, you're going to get tachyphylaxis, so the lower the dose you use that's effective, the better. So let's look at 2 or 3 possible new drugs. First is a Ghrelin agonist called relamorelin. So relamorelin, as a Ghrelin agonist, enhances gastric emptying, reduces the symptoms associated with gastroparesis, and as you can see in the cartoon there, it actually has an effect on vagal afferents to actually reduce conductivity through the nodose ganglion, and therefore it has effects on increasing gastric emptying, has an effect in the central nervous system on the hypothalamus to increase appetite, but it actually reduces vagal afferent function and therefore has some beneficial effects. The second possibility, now that it has been approved in the United States, is prucalopride, which is approved for the treatment of constipation, not for the treatment of obesity. But often we have patients who have constipation in whom a 5-HT4 receptor agonist given once a day, like prucalopride, may be beneficial. These are preliminary data from Jan Tak showing improvement in gastric emptying and also in the symptoms of gastroparesis. Aprepitant is an NK1 receptor blocker, and as you know, this is a drug that's used for chemotherapy-induced emesis. And the NIH Gastroparesis Consortium did a randomized controlled trial looking at the effects of aprepitant on nausea and other symptoms. Unfortunately, it didn't meet the primary endpoint, but several of the secondary endpoints, including the GCS high total score and nausea and vomiting, were actually improved. We did some analysis to try to understand how would a substance P antagonist, which typically you'd expect to inhibit gastric excitatory activity to reduce contractile responses, how might that be helping a patient with gastroparesis? We anticipated, for example, that it might slow gastric emptying as a NK1 receptor antagonist. And what we found was, and this is the method that we use at Mayo to measure gastric accommodation with SPECT imaging, we found that, in fact, aprepitant has an effect to enhance gastric accommodation, and that may, in fact, be how it induces its beneficial effects on symptoms. Finally, we've seen really exciting data. Well, GPOEM, this is just a systematic review meta-analysis that's just been published a couple of days ago. Clinical success, change in gastric paresis cardinal symptom index, and improvement in gastric emptying, all looks really very promising. And I think what we do need is a sham-controlled study to be absolutely sure as we go forward, and also to do the sorts of analyses that will try to help us understand who might be good candidates for this procedure. And perhaps indeed a pyloric stent would be one way to identify those patients. I'm going to move on to obesity, and our concept has been that really obesity is a problem of the brain-gut axis, and we see patients who have reduced satiation so that they eat more at a meal before they are feeling full, or they have a problem with satiety. They have an absence of hunger, which could be centrally mediated and possibly based in the hypothalamus or the hedonic hunger that comes from higher centers. But we also feel that there is an opportunity for us to learn a bit more about how the stomach works. Because when all is said and done, the most successful treatments for obesity have obviously been centered around changing the physiology of the stomach, as well as the incretin responses that result from, let's say, Roux-en-Y gastric bypass, passing the nutrients down into the distal small intestine to increase GLP-1, PYY, which then induce greater satiety. So we did a number of studies, and this is based on almost a database of 520 healthy volunteers or obese people. And what you can see here, and I'll go this very briefly, is that the volume to fullness, when you give people Ensure at a rate of 30 milliliters per minute, the volume till people feel comfortably full is going to be higher with increasing BMI. And indeed, this is not insignificant. If at every meal you eat 150 kilocalories more, 3 times a day, that's going to mount up, and you're going to end up with obesity. So satiation is an issue. We also found that gastric emptying for solids and liquids is accelerated, so that may explain the lack of satiation in these patients. Gastric volume is slightly higher in the fasting state, particularly for class 2 and class 3 obesity. Notice that all of the gastric accommodation volumes are quite normal, unless the patient has binge eating disorder or bulimia, where Galipta and colleagues have shown that the stomach volume is actually much larger. This is the way in which we measure the gastric volume using SPECT imaging involving technetium. So we identify a number of latent dimensions in obesity, and we can account for approximately 81% of the variance in obesity between satiation and satiety, psychological disturbances or behavioral disturbances, gastric sensory motor dysfunction, gastric capacity, and changes in incretin levels. Now, if you look at something like this enormous review of the different pharmacotherapies from Bray and colleagues a couple of years ago, you'll see that there are many, many targets pharmacotherapeutically for obesity. And my colleagues at Mayo certainly are very interested in the hypothalamic and the other central nervous system controls of appetite. But we in gastroenterology think that there is much more to be gained still from either interventions on the stomach or indeed medications that have effects on the stomach. So let me take you through some of that rationale. So if patients have an ability to eat an enormous amount of food at a buffet meal, you can see here when we did a small study with phentermine topiramate that there was a greater weight loss. But indeed, the greatest weight loss was in the people who have that increased appetite and are able to take a very significant and large amount of food. Similarly, when we studied patients who have accelerated gastric emptying, we showed that exenatide, a GLP-1 agonist, is able to induce greater weight loss than placebo. And we extended those studies in this study published about 2 years ago with liraglutide, a GLP-1 agonist, escalating the dose up to 3 milligrams per day. And as you can see there, you can see a very dramatic increase in the gastric emptying T-half that goes from around 120 at baseline to about 210 after 5 weeks, and it's still significantly delayed at about 170 at 16 weeks. Importantly, the degree of weight loss is determined by, or at least correlated with the degree of gastric emptying delay, suggesting that gastric emptying delay is a significant factor in the success of liraglutide in inducing weight loss. And as has been mentioned previously by one of the speakers, we know now that endoscopic sleeve gastroplasty also results in impairment of gastric emptying, and this is associated with weight loss. And also that after the presence of this intragastric balloon, you see the delay in gastric emptying. And if you look at the right upper corner of that slide, you'll see that the change in the gastric retention at 8 weeks is a determinant of the total amount of weight loss. The more gastric retention you have at 8 weeks by the presence of that balloon, the greater the degree of weight loss that is observed. Final point, there is tremendous opportunity and still not enough research done on the possibility of using combination therapy. We all know that when the gastric remnant in a RYGB, or gastric bypass, has expanded, endoscopic suturing or sclerotherapy can help. We know that sleeves really started as part of the biliopancreatic diversion with duodenal switch many years ago, and many patients lost enough weight with the sleeve that that was the stop point for those patients. But also, we also know that buprenorphine and naltrexone is a combination of 2 drugs. Phentermine topiramate is a combination of 2 drugs, and we're starting to see some really interesting novel approaches. For instance, the use of liraglutide or extended exenatide with intragastric balloon. There was one clinical trial that was recently published. And also newer combinations of hormonal approaches. For instance, there is one chemical entity that has an effect on both the GLP-1 and the GIP receptors, both of which delay gastric emptying, and both of which have an effect on reducing glycemia and improving glycemic control thereby. And finally, studies from Steve Bloom's group in London and England showing a combination of GLP-1 oxyntomodulin and PYY, 3 ileal incretins working together to induce weight loss, and partly through the inhibition of gastric emptying. So I think the opportunity for maximizing treatment through interventions on the stomach with all of our different armamentarium is really here, and we need to work more to bring it to our patients' care. Thank you very much for your attention.